Bueno, nada, muchas gracias a los ponentes. Ha sido una mesa de un nivel espectacular. Para abrir esta ronda de preguntas, me gustaría hacer la misma pregunta casi para el doctor Pohl y para Sergio. Y es, en pacientes con OFUEG, con obstrucción anal funcional, ¿hay algún test que a ti en la manometría, tú que usas tanto manometría como FLIP, te evitaría hacer, en pacientes con obstrucción, te evitaría hacer un FLIP porque un test de provocación de manometría es muy claro? And otherwise, for Dr. Daniel, I'm speaking about EGGOO patients. Is there any feature in the EndoFLIP that could avoid performing a manometry? Because it's very clear. So please start, Sergio.
Okay. A ver, yo pienso que deberíamos intentar, como he dicho, intentado plasmar a lo largo de la presentación, reproducir más en el laboratorio las condiciones en las que el paciente tiene síntomas. Es decir, creo que a lo mejor los casos de obstrucción al flujo no serían tan dudosos y a lo mejor no requeriríamos tanto EndoFLIP para aclararnos esos casos si recurriéramos probablemente más a la comida sólida, a los test, a cómo el paciente tiene los síntomas y qué es lo que vemos en ese momento. Lo que nos crea inseguridad es que pues, a lo mejor no hay tantos valores de normalidad y, claro, veo que aumenta el IRP, pero ¿hasta cuándo tiene que aumentar? Pero, claro, si veo que tiene un IRP aumentado, que la onda es una onda que se vuelve hipercontráctil, espástica o algo reactivo a esa obstrucción y el paciente tiene síntomas, creo que sería suficiente para poder plantear un tratamiento.
Okay. So, I think I totally agree that the idea of an awake patient having in your lab, it's really good to make sure that you try to reproduce the symptoms what the patient has. So I think provocative testing is super important. And I think you cannot have a dysphagic patient in your lab and just do water swallows. I think you're not using the technique right. So, so then you do your provocative testing, and I would argue solid meal has been shown well. Some of the data that you showed that come from our lab. And then you know, okay, there is some problem at the EGJ. But you don't know what that problem is. And if you give it to an endoscopist, he will also not know, because they don't look at the esophagus from a functional perspective, but rather from a morphologic. So what I find in a ton of patients who have EGJOO on test meal is, for example, an under-recognized Schatzky. You know, because the Schatzky is not 12 millimeters, it's not, or 9 millimeters, and your scope doesn't go through. There's nice data from the EOE community which show that your sensitivity to find a meaningful diameter decrease is 20%, 25%. That is useless as a diagnostic test, right? So in those patients, and we find a lot of these EGJOOs, the EndoFLIP gives you additional information. So for me, this is it's not an yes, it's not one or the other. For me, it's every dysphagic needs some manometry, in my opinion, plus provocative testing. But then you go back to the endoscopy lab, number one, to look further at it, and also to treat it. Because what we like to do is we like to treat them in the same session. So I think this is where FLIP really comes in handy.
Okay, it's very nice. So for Professor Zerbib, it is spectacular how you treat the inability to belch and how flatulence and bloating improves, which is a vast part of our consultation. Do you think we need actively to seek this syndrome under our dyspeptic patients or our IBS patients?
Yes. Now, in my practice, I always ask the question about belching, like I ask about heartburn, about dysphagia. It's on the list of the symptoms I am asking to the patient, yes.
Okay. Preguntas por la Carolina.
Vale. Muchas gracias por las presentaciones, han sido excelentes. My question is for Frank. So it seems that it could be a behavioral problem and that patients somehow have learned how to do this. But what have they learned to do? Is it that when they're going to belch, they close their upper sphincter, or somehow are they moving air from their stomach up and then closing? What is the mechanism?
Well, we don't know yet. I don't think that they make active retrograde movement of air. It is just because their lower esophageal sphincter is opening, but the upper one, it does not. And why? I don't know, but quite a substantial proportion of patients have emetophobia. They are afraid of vomiting. And they have this for a long time, even where they were children. And maybe this may somehow promote this kind of behavior. Being afraid of vomiting, you develop some abnormal behavior, and maybe, I don't say it is the explanation, but in the papers it is most 20–25% of the patients who have this symptom. And I have seen 1 or 2 in my patients already. So I can't answer your question, Carolina, because yet we don't know exactly what's going on with that.
Dr. Pohl wants to...
Yeah, I have a question for you, Frank. I was very happy that you showed the data about the side effects of endoscopic administration of Botox, and you described that there was 100% dysphagia after 4 weeks, 10% dyspnea, 10% dysphonia. And so I do this as well, and I've always been very stressed that my patients get dysphagia, and I don't see it in the literature, so that's great. Now, what about the dyspnea and the dysphonia? I mean, this is disturbing, right? I mean, also from a patient perspective, if you tell your patient your chance you're going to have trouble breathing afterwards is 10%, you know, I would think twice to do this. So how relevant of a dyspnea is that? And are we not doing it right? You know, should we more focus more? Should we put it somewhere else? I think the ENTs are doing a little bit of a better job currently.
I suspect so. I suspect so. But my explanation is that there may be some kind of diffusion of the toxin above and may goes into the larynx and something like that. And dyspnea is more probably the feeling of being out of breath, that really something that make you have a real dyspnea in the sense of they can breathe, but they feel something wrong in their throat, and they have the feeling that they cannot breathe normally, but in fact they can breathe normally. Okay. One patient went to the emergency room after my procedure because of laryngospasm. It is the opposite of a laryngospasm. I have injected Botox. It is not a spasm. It is a feeling of something's going wrong in their throat. But you have to explain that before to the patient. Otherwise, you will have hundreds of phone calls after your procedure. But I hope that in several years, I won't do it anymore.
Tenemos tiempo para un par de preguntas más, yo creo, de... Sí, doctor Santander.
Gracias. Quería I wanted to ask Dr. Pohl and Dr. Casanova about EndoFLIP. We have been using it for a few years in our center, version 2.0, and we have a hard time actually finding RAGs, normal RAGs, by the rule of 6. What do you think about the use of it to rule out patients with dysphagia and that actually have an approach to do just as a first test in a patient for dysphagia? Thank you.
So I didn't understand the first part of your question. You are using it in what patients?
We are using it mostly for EGJ obstruction,
yeah.
And now we're using it in some patients in the follow-up for after achalasia treatment. But my question was mostly on when you're evaluating a patient for dysphagia, we're not using it, but I wanted to know your opinion in finding RAGs, because we usually don't find the normal RAG pattern on the patients that we're using for other reasons. Yeah. So we don't know. We don't know if there is actually an approach for patients with dysphagia, and that you're trying to, because there are some publications that use the FLIP as a first approach in patients for dysphagia. I know is mostly from the U.S. But we don't really think that we're going to find actual RAGs on those patients. Yeah.
So we do find RAGs. I mean, number one, maybe your patient selection is very good because all of your patients are abnormal. So, you know, basically then you don't find RAGs. And you're right that the approach from the US has been a little bit to use or to advocate this as a pre-screening or a screening test, basically. However, if you do find RAGs, then the chance of having an abnormal anything, manometry, barium, is very low. So having said that, the few that you find, the possibility, it probably is a good screening test. However, you cannot exclude a lot of patients. I guess that would be the answer to your question. We do see RACs, sometimes in reflux patients, sometimes in patients who have questionable EGJO, because if you look at the normal values, you know, they're machine dependent of the IRP, depending on what system you're using. So you find a ton of people that have an IRP of 12.7, right? Is that meaningful? We don't know. So we're happy to have the flip there that excludes it. But I think it's okay as a screening test if you look for RACs. I personally do not use it as a screening test. For me, it's a complementary tool, it's an adjunctive tool, or it's a tool in patients that do not tolerate catheters.
Congratulations for all of your presentation. Professor Pohl, I would like to have a practical question. In achalasia patients with esophageal dilation, do you always perform EndoFLIP at what intervals? It's a practical issue.
Yeah, I do. I actually, what I do is I do the EndoFLIP to confirm the diagnosis / measure the DI and distensibility. And then I do the dilation right in the same setting. So I have two machines set up. One is set up for diagnostic purposes and one is set up for therapeutic purposes. And then I treat either with the EsofLIP or if I need a larger dilation tool, I use the larger ones which are available, Rigiflex 35 or 40, and then I remeasure right away with the EndoFLIP afterwards to see if I have a relevant delta both in diameter, in distensibility, and I also look at pressure, because if you get rid of the stricture or if you get rid of the functional, I use this for anything basically, for anything that's tight, then you also see a delta in that. So I think that's the most elegant setup. The downside is you need two machines to do this, right? And that's a lot of money to be spent. So I accept that this is not going to be universal standard. I hope that they'll make it a little bit easier to change catheters, so you can do an EndoFLIP, an EsofLIP, an EndoFLIP possibly with one machine, but then you still need two catheters, right? You need a diagnostic and a therapeutic. However, good news, the therapeutic catheter is half the price of the Rigiflex, so that's a good news.
We are very lucky, but for us it's a challenge nowadays. Si puedo hacer una pregunta al doctor Casabona, muy rápida. La decisión de realizar los test de provocación, a veces no tenemos un diagnóstico, hemos hecho las 2 pruebas de provocación o 3 pruebas de provocación durante Chicago 4. La decisión de continuar con alguna más, comida sólida, ¿qué pacientes deberíamos seleccionar?
Bueno, eso es lo que tenemos que tener es tiempo para poder hacer una buena anamnesis historia clínica, porque muchas veces ya desde que estás preguntando al paciente antes de hacer la manometría ya puedes pensar si ese paciente va a ser candidato a lo mejor a darle comida o a darle una dilución viscosa, etcétera. Entonces lo primero es eso. Muchas veces no ha traído comida al paciente o no lo tienes preparado, pero bueno, siempre en la planta, pues como he dicho, compota de manzana, pan y demás, pues es lo que solemos utilizar si tenemos que recurrir de urgencia a ello.
Gracias, Sergio. Yo creo que podemos dar por concluida esta mesa. Muchas gracias a todos por vuestra atención y gracias a los ponentes, por supuesto.